Recording thing. All right. Well, I want to welcome Dr. Susan Harwell tonight, and she has the either the pitiful job or the great honor of being my rheumatologist. I think it depends on the day, but she practices with Heritage Medical Associates, and she received her medical degree from the University of Tennessee and her internal medicine training, and she did a rheumatology fellowship at Vanderbilt. You guys have met some of the other Vanderbilt rheumatologists, and she's originally from Winchester in Southeast Tennessee. So welcome, Dr. Harwell.
Thank you. Thank you guys for coming and taking your Tuesday night to learn a little bit more about lupus. Whether you have it or a loved one has it or whatever your interest is, it's always good to know more. Now, I do have a PowerPoint, Tracy. I do not know if I know how to share my screen.
Okay, there's a little button in the center below that says share screen, and you can just click on that and it'll let you see your windows.
Okay, wonderful. There it is. Share. Okay, great. Can everybody see this talk? Okay, so I have the difficult task, I think, of talking to you guys about the battery of lupus testing that is ordered and what it means to the rheumatologist, and also what it means for you and your presentation, and maybe just some pointers on how you can look at it and how you can think about it. I have tried really hard to keep this at an understandable level, but if I have failed, please interrupt. This can be more like a conversation and ask any questions that you have as we go forward, okay? All right, so, and I also give this talk to a lot of budding doctors, residents, and fellows, and so I'm always telling them, you know, when you're ordering any test as a doctor, it's important to know what you're going to do with the results of the test. So as a patient and as an advocate, you should know this too. If a doctor's ordering a test, why are they ordering it and what are they going to do with the result when they get it? Will it change management? And then a second important concept is that autoantibodies are a small piece of a greater puzzle. So having an autoantibody alone is not enough to make a diagnosis of a disease. And autoimmune diseases are largely clinical. So you do need to have some clinical features of the disease before you get diagnosed with it, because this is a common consult I see is positive ANAs, and I have to talk people off the ledge often. So just generally about autoimmunity, you guys have probably seen something like this before, but you'll have a genetically susceptible person. So somehow this was written into your genetic code that you can get an autoimmune disease, and then something happens. And we don't know what that something is. There are lots of theories. It probably varies from person to person, but something happens and sets off the cascade where your immune system first becomes activated. Downstream, your body starts forming autoantibodies, and we're going to talk a little bit more about that in a few minutes. And then you start to get autoantibody mediated clinical symptoms. So that's where you start to get symptoms of the disease. So ANA, what is that? This is the big test that everybody who has lupus has had. So I always want to start off by just saying, kind of going back and reminding you of what all these words mean. So an ANA is an anti-nuclear antibody. An antibody is a Y-shaped protein that is our body's defense against foreign, what we call proteins or antigens. So namely bacteria, viruses, something comes in, we neutralize it with antibodies. It also is kind of our body's memory, so that as you continue to be exposed to different foreign invaders, your body can remember them and neutralize them more quickly the next time they see them. So they're typically used for immunity against bacteria and infection. And then also as a reminder, your body is composed of millions of cells. And, this top right picture is a picture of, those are antibodies neutralizing what appears to be a coronavirus. And then your nucleus is the center of each cell. So your body is composed of millions of cells. And in the center, sometimes it's a little off center of each cell, is the nucleus. And that's kind of the brain of the cell. It contains all of the DNA and kind of the programs for the cell, and kind of dictate what the cell's going to do in your body. In the case of ANA, or anti-nuclear antibodies, your body is making antibodies towards the nucleus of your cells. So it seems like that should be abnormal. You shouldn't be making antibodies against yourself, right? You should be making antibodies against things that are foreign, not yourself. So this is not normal, so to speak. However, you can have a positive A and not have a disease. So this is just a graph that, in this particular study, they just took blood donors, 500 blood donors, and then measured their ANA. So they were asymptomatic people. They didn't have a disease. And you can see, and we're going to talk about what these numbers here on the left mean. But the important number is down at the bottom, and you'll see that about 22% of all of these blood donors had a positive ANA without symptoms. And you'll see this number reported from anywhere to 15 to 30%. And of course, at the lower levels of ANA, there's more people that are positive, as you can see here. And as that ANA becomes more positive, more markedly positive, it's less. But even at those high numbers, you do see positive ANAs in people who don't have diseases. But the ANA connective tissue diseases are not just lupus. So if you do have some sort of ANA related disease, you might have lupus, but you could also have scleroderma. And there are a couple of different types of scleroderma. You could have Sjogren's syndrome, which is very common and commonly seen along with lupus. You could have an inflammatory myopathy, or you could have mixed connective tissue disease. And all of these have different presentations. And I'm not going to really go into this today unless somebody's just really interested in it. But, we think of ANA as typically being a screening test for lupus, but I'm always careful to tell my patients it's for lupus and lupus-like diseases. And ANA is seen in other diseases too. So patients will often ask me, why is my ANA positive? Sometimes it can be seen, if you look kind of here in the middle, it can be seen because you have cancer or you've had an infectious disease that's caused an ANA to become positive for a brief period. Even fibromyalgia patients have positive ANAs. So there are lots of, I've seen lots of rheumatoid arthritis patients have a positive ANA early on. So we see these in other disease states as well, just to kind of broaden your knowledge of what all can happen with ANAs. So does anybody have any questions about anything I've said so far? I don't know if I can see the chat.
Sorry, I forgot to unmute myself. Nothing in the chat right now. So okay. Does anyone have anything at this point? Okay. All right, let's keep going.
Awesome, great. Okay. So your doctor, you've gone to your doctor, you have some kind of symptom. So I've kind of just given you some background about the test. Now you're at your doctor, you have some kind of symptoms, and your doctor has decided to check an ANA. Well, there are two different ways the ANA is checked, and it may even be that your doctor doesn't know which way their lab checks it. So I will often see the second way checked, and then when I recheck it, it'll be negative. So the first way, the gold standard way, is to do an immunofluorescence study. And I didn't go into detail about how this is done, but this is where a labor-intensive process where they're actually plating your serum along with, serum with antibodies, and then a person is looking at it to determine if it's positive or not. And this is, you need a skilled person who's done this before. It is somewhat subjective, and it takes time. You'll also get titer and pattern with that information. We're going to talk a little bit about the titer and pattern. This is something you've all seen if you've looked at your ANA reports before. The ones that I'll see done a lot in very busy primary care clinics are bead assays. And these are good because they're cheap, they're easy, they run through a lot more quickly. But there are a lot of false negatives and false positives. So it's not uncommon for me to see a bead assay and just repeat it because it is not always very accurate. So when we see them when they're done by immunofluorescence, we're given a dilution. And so that's what we're talking about when you see 1 to 40, 1 to 80, 1 to 60. What they do is they dilute your serum with the serum that they're using in the test. And they start by diluting it 40 times. If they see anti-nuclear antibodies in that, then they do it again and they double it and they dilute it times 80. A dilution of 1 to 80 your serum, 80 of the antibody, and they keep diluting it. So the more dilute your serum is, if they're still able to pick up an antibody, that means your ANA is more markedly positive, okay? So the higher that second number is, the more markedly positive your ANA is. And that does matter, because if it's very low, if it's just 1 to 40, that's the lowest possible detectable level. And many rheumatologists are just going to throw that out and say that's probably negative. It's really 1 to 160 sounds high, but that's really considered a low positive. And so your rheumatologist is going to take that into consideration. If you see one that's 1 to 1280, that's going to be a strongly positive ANA. Okay. And then you'll also see patterns. So if you've ever seen your ANA, and these are not on the bead assays. On the bead assays, you just get a positive or a negative. They will not give you titer or pattern. So if you have this done by immunofluorescence, you'll also get a pattern. It'll say something like homogeneous or speckled, or there are lots of them. And we're going to talk about some of the most common. And the way they see this, and I didn't put any pictures up, I should have. These are looked at under a microscope and are immunofluorescence. Imagine a little black cell with neon green. And to me or to you, they might all just look exactly the same. The difference between a speckled and a homogeneous and a centromere pattern can be pretty difficult to tell unless you're just really skilled at doing this. You've been doing it for years. You've been taught by someone. But they do have disease associations. But like I said, they're subjective. We take them into consideration, but it's not uncommon to see them be different from test to test because it was read by a person. And now that we know about the specific antibodies, which we're going to talk more about in a moment, this is not the most important thing that we see. We don't base anyone's treatment or anything based on these patterns, unless it's maybe centromere, because that one's very specific. But if you have an ANA, for example, that's 1 to 320 homogeneous, a homogeneous pattern is associated with lupus. If it's nuclear envelope or rim, this is a very rare pattern. I'm not even sure I've seen it. That one is tightly associated with lupus. The most common pattern is speckled. I'd say the majority of the ANA patterns that I see are a speckled pattern, and they're seen in almost all the different Sjogren's, lupus, myositis. You can see a speckled pattern in many of the ANA-related diseases. Centromere pattern is seen in CREST syndrome or limited systemic sclerosis, which is a very specific disease state and is not lupus, but that pattern is fairly specific for that. Nucleolar is seen in scleroderma and polymyositis. And then I just bring up dense fine speckled. This is one I've been seeing a little bit more commonly, and it's typically associated with the absence of autoimmune disease. So that's usually a good prognostic factor, although you can have lupus and have a dense fine speckled too. This is all, again, just pieces of a bigger puzzle. And there are many other patterns I've seen. I think some of the labs are coming out with a lot of different patterns, and they all have different proposed disease associations, but nothing set in stone. Okay. Sometimes it feels like when we're rheumatologists, we're almost like reading tea leaves in a way. Okay, so these are the extractable nuclear antigens. These are very important, and these do have very specific disease connections. And now that we have these, this is why we don't care about the patterns quite as much, because we can identify which actual specific nuclear antibody you have positive, and that has meaning in terms of what your disease might look like if you have one. Okay. And I've listed these in a different way on another slide, which may be kind of easier to consume. But this top one is just talking about a regular old ANA. And you can see, you see those in all patients with lupus have a positive ANA. We don't, because of all this, we don't see ANA negative lupus really anymore. But all of these ANA related diseases will have an ANA. And then you see this anti-double-stranded DNA that's very tightly associated with lupus. Anti-histone antibodies are seen, you can see in the second column, drug-induced lupus. Smith antibodies are seen in lupus. And you can see that sometimes you'll have these antibodies in other disease states, and that's why they're all listed here. But each antibody kind of has a very tight association. And I've kind of listed these out here just to, this is what the rheumatologist is thinking about when they see these specific extractable nuclear antigens be positive. So double-stranded DNA is always going to get your rheumatologist concerned about the possibility of lupus. Histone antibodies are seen in drug-induced lupus. So if you're taking, you know, an old blood pressure medicine called hydralazine, or there are other drugs that are commonly associated with drug-induced lupus, they will get a histone antibody. Smith is associated with lupus. RNP is seen in mixed connective tissue disease. SSA and SSB, Sjogren's, also seen in lupus though, but yes, you see them in Sjogren's. That's what they're mostly associated with. SCL70 is the diffuse form of scleroderma. Centromere is the limited form of scleroderma. And then JO1 is seen in a syndrome called antisynthetase syndrome, which includes arthritis. It's kind of lupus-like. It has muscle disease and has some overlap properties of many of the ANA-related diseases. And I just come back to this, and I just realized when I was reviewing this before I came on to talk to you guys, it's important to remember why you're checking these. So if you, these are the classification criteria for lupus. And this is really meant for clinical studies, you know, but it is relevant when we're thinking about our patients. So when you're looking at a patient, or if you are a patient and you have symptoms, these are the types of things your rheumatologist is going to be looking at, thinking about, asking you to figure out, do you have lupus? And so the clinical criteria are two different types of rashes. One of the acute lupus rash is the butterfly rash that you're probably familiar with. There's a different form of lupus that's scarring. That's a skin condition. The ulcers in your mouth, the hair loss, arthritis. Serositis means inflammation of the lining of your lungs, so fluid on your heart or lungs, or pleurisy. They'll be asking you about kidneys, protein or blood in your urine, headaches, seizures, anemia, not just iron deficiency anemia, but they're going to want to know if there, you know, has anybody ever told you that there could be an autoimmune component to your anemia? Leukopenia means low white blood cells, and thrombocytopenia means low platelets. So these are kind of the criteria. And then we also check the labs that we just discussed. Well, we discussed some of these. You'll see Smith very tightly associated with lupus, anti-double-stranded DNA. And so you have to kind of meet these criteria to get the diagnosis of lupus. And this is why your rheumatologist is asking you all those off-the-wall questions about what your symptoms are. Okay, so that kind of is the section I have on the lupus labs. Does anybody have questions about this?
You guys can unmute yourselves if you have anything. There's nothing in chat yet.
Okay, good.
This is great information.
I
Good.
have a question.
Good. I hope it's consumable.
Absolutely. Bernadette's got a question.
Oh, good.
I had an annual checkup last week, and I had surgery the first week of February. And during that surgery, after the surgery, I fell once, and I had a dizzy spell. So my GP told me she was going to run some tests. So I got my test results back today, and my white blood cells and my monocytes were out of range. My white blood cells were low, and my monocytes were high. So I asked her, what did that mean? And was it anything to be concerned about? And she wrote me back, no. And that she'll just check back with me in 6 months. And I didn't think that was a reasonable answer.
Well, so I have many lupus patients who keep a low white blood cell count, just it's their baseline. Do you know what your white blood cell count usually is?
I think it's always been in the normal range because I get when my rheumatologist do my blood work,
Ah,
that'll be sent in to me also. But he hasn't done it in almost a year. He told me that I was in remission, even though I keep going to him complaining, and he's saying that it's arthritis and not lupus.
ah.
So that's why I was concerned when she ran the test. And I
Well,
got
I can understand why you would be. With a history of lupus and a low white blood cell count, that is something we look at when we're thinking about lupus activity. So you might meet back up with your rheumatologist and, tell them what's going on. A one-time low white blood cell count, I know if it were me, I'd want to repeat it and make sure it was still low. And you might want to check your neutrophil count because that specifically can be low in lupus. And we're going to talk about lupus monitoring. There's a lot of other parameters that can be checked to prove, not to prove, but to just make a better picture of, do you have active lupus or not?
okay.
It's hard to know because, in infections and in stress like surgery, you think that your white count should go up, and it usually does, but sometimes it will drop a little bit too. So it could have just been after surgery, your white count dropped a little and maybe it will recover. It's really hard to know.
All right. Thank you.
Mm-hmm. Okay. So now we've talked about what ANA antibodies are. We've talked about all the details and the weeds about all the titers, patterns, and extractable nuclear antigens. So now you have a diagnosis of lupus. How is your rheumatologist going to monitor it with blood work and urine? So the first thing is, patients are always asking me, should you recheck my ANA? Will you recheck my ANA? We have not found that the ANA value itself fluctuates or really changes with disease activity. It doesn't mean it doesn't change in general. There are, reports of people with lupus as they go into remission, maybe their ANA becoming negative. Long-term use of Plaquenil can sometimes make ANA negative. But it doesn't, because if you have active lupus, your ANA titer doesn't jump to 1 to 1280. Your ANA titer does not reflect your lupus activity, okay? But there are things that do, and we're going to talk about those. The most important one probably is double-stranded DNA. We've already talked about how this is a very specific antibody, and these are, when I say double-stranded DNA, I'm talking about an antibody to double-stranded DNA. So I'm simplifying it. That's how we talk about it when we're just discussing it amongst ourselves, but it's really an anti-double-stranded DNA, just to be technical about it. But when these antibodies are present, they don't in everyone, but they do tend to fluctuate with disease activity. So if I have a patient who maybe is losing weight and feeling a little more fatigued, and I check her labs and her double-stranded DNA is starting to trend up, I'm going to be concerned that her lupus is active. And on the same token, if it went up because it was active and I gave them a course of prednisone and it came back down, I'll feel reassured that we got it back under control. So that's one marker. Complement levels are another marker you'll see a lot as well. Complement is an important part of immunity. It kind of cleans up debris, and it's important when there's antibodies kind of being deposited, what we call immune complexes being deposited. It's important to that process in a normal body. Now, lupus patients will sometimes have low complement levels at baseline, especially C4. And we think that that is somehow related to their lupus. But another thing that will happen is that during active lupus, sometimes their complement levels will go low. So not high, they'll drop. And this is very specific to lupus. There's only a list of maybe 5 things in medicine that causes complement levels to be low, and one of them is lupus. So this is another thing you'll see rheumatologists checking at your routine appointments. If they see your creatinine going up and up, and so they check your complements and they're low, they're going to be really worried about your kidneys and maybe get you in for a biopsy and get you on steroids. Okay. So this is another marker of disease activity in lupus. They're always going to be checking your urine. Sometimes kidney disease can be a silent problem in lupus. You know, you don't really feel it unless you start getting swelling in your legs, but it doesn't make you feel worse, or it's not an active symptom. So by checking urine and looking for protein in blood and what we call casts, which are kind of broken up cells in your urine, we can catch kidney involvement early and do something about it before it causes major organ damage. So they'll probably be checking your urine frequently. We also just check basic labs, kind of like Bernadette was saying. You know, if your white count drops, that could mean active lupus. It could also not, but it's just one of the pieces of the puzzle we're putting together to try to decide, could you have active disease? Sometimes patients with lupus will get a autoimmune problem with their platelets, and so we're checking for that. We're also going to be checking, just looking at your kidney function and your liver as well. So you know, rheumatologists may choose to do these at 3 to 6 to 1 year intervals, depending on how long you've had the disease and how long it's been since you've had symptoms. These are all things they'll be checking. And so then I just was going to finish with some scenarios. Does anybody have any questions about lupus monitoring?
We've got a question in the chat from the Collins family. What is an acceptable low blood count? Her range stays around 1.9. How low is too low if that's her normal range?
That's a great question. 1.9 is definitely low. Your rheumatologist is going to be more interested at that point in your platelets. I mean, not your platelets, your neutrophils, excuse me. So when your neutrophil count drops below 1.5 or 1500, you're called neutropenic. And so you may not be able to fight infection as well. Now, that being said, I have lots of lupus patients who I get called by the lab every single time I check their lab because their white count is really low and it's just part of their lupus and it's chronic. And they seem to do fine in terms of infection. They don't suffer with a lot of infections, despite the fact that I have them on immune suppression. So that's definitely low, but if it's stable and not changing, it's probably acceptable. And you know, what's an acceptable range? It kind of varies from person to person.
Okay, because my neutrophils, looking at my last lab, were like 44, and then there's another one that says neutrophils absolute 1.0 low.
Right. So that means you have 1,000 neutrophils. So you'd be technically considered neutropenic. Do you get a lot of infections?
Not usually, no.
Right. So, I mean, as long as you're able to fight off infection, I'm not sure you would necessarily need to be on medication unless you had other manifestations of lupus. I mean, it, you know, it kind of, as long as it's remaining stable and not getting worse, your rheumatologist is probably just monitoring that.
Yeah, that's what he's doing, is just I go in for labs like every 3 to 4 months.
Yeah, for somebody with that low of a white count, I'd be seeing that person every 3 months. And if it stays stable and that's just always your white count, and you don't have any trouble fighting infection, then you know, you might get more comfortable with that over time. But you definitely want to be monitored closely at first. Another thing that can happen is a lot of the medicines that treat lupus can cause your white count to drop. So sometimes that can be a problem because you're trying to treat lupus anyway, for example, Urine, and then the white count drops even further. That sometimes makes us nervous. So.
Okay, and then also I have issues sometimes my CK levels, you didn't mention that, but they seem to spike, and they can go up to like 300, 400 or something like that. They've spiked up, and then he's had to monitor that and some other stuff. Then
Well, so
was it higher than that too? I can't remember at the moment.
Well, a CPK level is seen in mixed connective tissue disease. So not to be too technical, it's kind of like lupus. It's lupus that has features of inflammatory myositis too. And inflammatory myositis is an autoimmune disease against your muscles. So if that's part of your condition, then they will be monitoring those levels as well. Now, I don't know what the level was. But CPK levels definitely fluctuate, especially if you have a history of myositis.
So you can have that and lupus at the same time?
Well, your disease, I don't know everything about your labs and your profile, but it would probably be more accurate to call your disease mixed connective tissue disease. It's kind of like lupus, except with more features of other connective tissue diseases. Calling it lupus, I think, is not wrong, and not, if it makes it easier for you to think of it as having lupus with myositis, I think that's fine. But I think if you were going to just be really technical about it, it might be a mixed connective tissue disease. But I don't know. I haven't, like I said, do you have an RNP positive?
I don't know that. I'm looking right at my last lab. Is that something that usually?
This would have been in your initial lab set at diagnosis, probably. The first time.
It's called an RN, what is that?
RNP. That was one of the extractable nuclear antigens we were talking about earlier that's seen more in mixed connective tissue disease, which is a lupus-like disease. You can have the features of lupus with the low white count and the thrombocytopenia, all the features of lupus, but with muscle involvement, and has a little bit more tendency to involve your lungs as well. That's rare. And I don't know if that's what you have. I'm not trying to.
Right.
Yeah.
Right. Okay, well, thank you.
Mm-hmm.
Thank you, Jasmine. And we've also got a question from Beth. If you keep microscopic blood in your urine, but not visible blood, is that acceptable and common in lupus?
That's common in general. There are just some people in the population who keep very low levels of blood in their urine. And so sometimes we'll send them off to a urologist to confirm that there's no problem there. This is a common finding in people who also have interstitial cystitis. But as long as it's been there for a long time, we don't worry too much about low level trace blood in the urine. There are some people and families who just have that.
Thank you. A question from Jessica Azrin. How can they tell if it's autoimmune anemia? What are the tests to tell between regular anemia?
Yes, so I didn't include that, but the test would be, you can check what's called a Coombs antibody. So, and that helps you know if your body is making antibodies against your red blood cells. You can also check what's called an LDH, that will be elevated. And you can also check a bilirubin level. And so if you're breaking up your blood cells, your bilirubin level will be higher. So there's kind of a host of labs. It's part of an autoimmune hemolytic.
How do you spell those?
So it's Coombs, COOMBS, and they do a direct and an indirect, and then you can check an LDH, and you can check a bilirubin, direct and indirect. I'm not spelling them, am I? Sorry.
No, it's all right. I got that last one.
Coombs is COOMBS.
Okay, that was the one I was confused about. Yeah.
Yeah, sorry. LDH is just the letters. Bilirubin, you've got, and then sometimes they'll check a reticulocyte count. But there's kind of a workup for that. And that's after you've ruled out iron deficiency. So they'll often check iron studies. Young menstruating women will often be iron deficient, and so they'll have anemia in that way.
Yeah, I always have low iron.
Yeah.
We have got a question from Judith. Are you done, Jessica?
Yeah, I think so.
Okay, sorry. I'm trying to keep it moving. I'm Vanna White. Judith, are you going over lupus medication monitoring and toxicity? She's interested in MPA.
No, I wasn't. What? I'm sorry, she's interested in what specifically?
MPA.
Microscopic polyangiitis.
Plasma, yeah.
Okay, so
She's had some drug toxicity. Judith, you want to pop on and tell her?
Yes, am I on now?
you're on, yes.
Okay. I had plaquenil toxicity.
Oh.
And so we've been, because I also had a vision loss, and because of the optic nerve, I'm limited on what we can use according to my rheumatologist. So I was on mycophenolate, and I've been moved to mycophenolaic acid.
Got it.
And that's what I'm taking now. And I've just had I asked for the first, I've been taking one or the other since November, right after Thanksgiving. So I asked for some monitoring this last time, and there was one test, but in reading about it, I understand there's also a test for, I think it's called MPAG. So you can check the liver enzyme to make sure it can break it down. So I was just trying to figure out if you were going with that. If not, that's okay. But I was specifically interested in that particular one.
So for mycophenolate, I check your CBC and your CMP, which I have up here. That's your complete blood count, your comprehensive metabolic panel. And I check that more frequently when I'm first starting it. And then I check it less frequently, at least every 3 months though. I think what you're referring to, and I don't know the specific name of it because it goes by different names at every lab, but you can check mycophenolate breakdown products, and the gastroenterologists do this a lot. You can get kind of a picture of, if it's in an appropriate range or not. And I find I don't check that a lot. I don't do that test a lot. I just kind of go by clinical symptoms, and then I check the regular monitoring for toxicity. I think that what you're talking about is looking to see if the medicine is at an therapeutic level, but I'm not sure.
Right, I think that's what he's checking for with the first test. The range is like 1 to 3.5, and the other test was not checked. And I just read about it, so I just wondered if that is normal to check both to see, first of all, how much is in the blood, because we were talking about reducing it. I'm not happy to be on this. I don't have a transplant. I'm not really happy about being on it. But I understand, but I like the idea of checking to make sure my body's able to break it down, that I have enough enzyme to break it down to protect me. And that's what I was looking for, is both rams of it. So and I'm being seen again in 3 months. So I'll just ask another question. And I appreciate you taking time away from the general discussion to talk to me about this. And I apologize to the rest of you all.
No worries, Judith. We're glad to have you here. I think lupus patients are the best educated patients.
Yes.
I'm getting better. I've been sailing along for years just fine, and then all of a sudden, everything hit. So I'm learning a lot very quickly.
Thank you, Judith. Okay, that's all that's in the chat window right now.
Okay, well, I just was going to show you guys and lupus is such a broad disease. Somebody has a question. I think I heard someone say they have a question.
Sorry, if you had one more second.
Yes.
The question, like with all the levels being shown, this is Jasmine's husband. I don't know if this is a valid question or not, but you see like the C3 levels or the low blood count. Is there any resource to go to, like we had a dietitian on before, where there are things that you can do when you see certain levels skewed, either too high or too low, that you can do to assist with that other than just the medication? Because the medication has had positive results, but are there things dietary or other things when you see, say your C3 levels are high, is there something you can do? Or if you're personally? Is there like a resource of
You
to go
know,
to?
not that I'm aware of. Because, and I think the reason is because when the double-stranded DNA or the complement, or when these levels are off, we're worried about organ damage. Now, so we're going to want you to do, as if I were the rheumatologist, I would want you to kind of treat this medically with medication management, because I'd be worried about organ involvement. But in terms of, is there something you can do that's more complementary and alternative, or dietary, that you can take control of a specific level and alter it? Not that I'm aware of. They're just, when people, the studies looking at diet and lifestyle modifications have not been as specific as to look at how they might affect a particular component like this. Not that I'm aware of. And we continue to just be able to advise an anti-inflammatory diet, which is lots of fresh fruits and vegetables, and avoiding processed carbohydrates. Anytime you can choose between white and whole grain, always choose whole grain. And that's, avoiding sugars. That's the best we can do right now.
Okay, thank you. I appreciate it.
I can't unmute myself. A dietitian talked to us. In fact, we're kicking off an 8-week program with a registered dietitian on a food first program that includes a 6-week elimination diet. So we are providing that for 15 lupus patients, thanks to a sponsor.
Well, that's great. And I was going to say, I think that there probably are dietary things you can do that make you at least feel better. I don't know if they'll affect your lab values, but I always tell my patients I'm reluctant to give one recommendation, because what helps one patient may not help another patient. And so that is when you need something like an elimination diet to really get down to figuring out what affects you specifically, because your microbiome contains, zillions of bacteria, and it's different from person to person. And so that's going to be very person and patient specific.
All right. Thank you.
Can I ask a question?
Mm-hmm.
Which, first of all, thank you. This is fabulous information. And I think Tracy's right. As lupus patients, I think we just, since it seems so nebulous, right? We just want to know all the information we can. So thank you. I've had the fortunate opportunity that my blood work has started to become normalized. And from what I've been told, that the lupus is in remission, but I still wind up having symptoms, fatigue and the lupus rash. And I love my rheumatologist, and she had said that there's a difference between like the blood work looking normal and how you feel. Have you found that with like patients as well?
Absolutely, especially in, in some ways, I don't want my lupus patients to have organ involvement, but in some ways that's the easiest thing we treat, because we can identify it with our lab markers and with our, with our markers. But the fatigue, the pain that comes along with it, the brain fog, which is often just part and parcel with lupus, especially as lupus goes into remission. I see a lot of patients develop more of kind of almost a fibromyalgia-like syndrome with lots of fatigue. And I think there is an inflammatory component to that. And it doesn't necessarily show up in terms of our complement levels being low and our double-stranded DNA being high. It doesn't make treatment any easier, because, for really bad flares, we can still treat with a little prednisone taper here and there, but you can't do too much prednisone because that's dangerous. So we just keep our patients on Plaquenil, and we're just waiting for the next big thing to try to help us with the lupus fatigue and kind of those symptoms that we just can't identify with something that you can hang your hat on, with something objective.
So then would you say that a lot of the blood work and the C3s really is the focus of trying to make sure that the organs are healthy, and that the lupus is not affecting the organs? Is that when someone says that you're in remission, is that kind of what that means? Or
I think so. I think when someone says you're in remission, it means they don't see any evidence of inflammation affecting those organs. I think that'd be fair. Lupus is tough though, because lupus can do anything, and you could be in remission for, I'm almost reluctant to tell people that their lupus is in remission. I almost use more prolonged inactivity or something, just because it can pop back up at any time. And the other problem is that when lupus involves your brain, oftentimes all of these complement double-stranded DNA, they do not trend with neurologic activity in lupus. So I know at Vanderbilt, they're doing a lot of studies looking at brain fog and lupus and memory issues in lupus, because that is, talk about nebulous, that can be very difficult to pin down and diagnose. But I definitely think that it probably is related to your lupus. Your lupus may be inactive in terms of organ damage and involvement that we're able to identify. But if you're still having symptoms, I think it's fair to say it's still your lupus. Does that make sense?
Yeah, oh, absolutely. Can I follow up with one more question? I don't want to take
Yes.
time. You had mentioned that cognitive study. I think Mementine, I think Tracy is the one that you had talked about, the one that's Vanderbilt's doing.
That's right.
Yes.
Yeah.
I'm actually going to go on Friday to see if I'm eligible. They're going to do a cognitive test.
Yay.
Yeah, so I'll keep you posted. I don't know if anyone else has done it, anyone else on the call, if they've participated or not, but is there any test from the rheumatologist standpoint to address the brain function part, to see if, is it more of just anecdotal information from the patient standpoint of things that they're noticing? There isn't a test at all, is there?
There's not a blood test that I'm aware of. There may be some sort of questionnaire that has been designed for the intention, and Tracy, you may know this better than I do, that's been designed for the intention of studies. I know that Leslie Crawford's working on this.
Yeah.
So I do neuropsychiatric evaluations for people with brain injuries and things like that. And there are a few different measures that you can do that are clinically rated, that, that they've scored in a way that is standard. So you can figure out how far, high and below, a lot of like word recognition kinds of things. Memory is probably the big one. I could probably run you guys a memory test anytime, but yeah, that's what I would expect them to use if it's an actual clinical study. Self-report isn't so great, but these tests are pretty good. And
they're
pretty
going to
standard.
have some sort of validated questionnaire that they're using in the study. And I don't know if she's going to take into account any lab or blood parameters. I don't know. I'd be interested to know.
In that Mementine study that you're talking about?
Yeah, I can reach out to her.
Yeah.
I'm planning on asking her to talk about it. So
good.
Our session. So yeah, she's great about doing stuff.
Yeah, they told me that they'll do the cognitive test, and then they draw 12 vials of blood. 6 is for the study to see if you're eligible, and then 6 goes to just lupus research. So they said even if you're not eligible, you're still kind of helping the cause. So, and it is cool. That Dr. Crawford, Lisa Crawford, I believe is the name. Yeah. So I'm excited. So we'll see how that goes. I go on Friday. So.
Well, great. Good.
Thank you. Thank you for answering my question.
And I believe wasn't Dr. Crawford? Didn't you train under her?
She was. So her first year at Vanderbilt, I was her first. She was my mentor. So all of my clinical. Anytime I do an injection or I see a patient, I'm remembering Dr. Crawford's voice is in my ear.
Oh yeah. So Nicole, you can say thumbs up. Good job.
Excellent. Thank you.
All right. That's all that's in the chat window right now. So you can keep going.
And I don't know how useful this last bit will be, but I just thought I'd share with you kind of 3 different scenarios. And I was kind of saying that there are so many different presentations, and this is my most common consult by far, is seeing people with a positive ANA. But these are just kind of 3 scenarios to try to take what we learned from the blood work and put it in a clinical picture. So first we have a 28-year-old female who comes in with swollen lymph nodes and swelling in her legs. And so her primary doctor checked a host of labs and sends them over to me. And we have an ANA that's 1 to 1280, homogeneous with a positive Smith and double-stranded DNA. So I feel like almost this is too repetitive, but this is a high positive ANA. Homogeneous is a pattern that we see in lupus. Smith and double-stranded DNA tightly associated with lupus. She has low complement levels and she has protein in her urine. So I am very concerned about this patient. And so this is a real patient. I'm sending this patient for a kidney biopsy and I have them on steroids. So this lab work is going to get the attention of your rheumatologist. In the set, I mean, you know, if it's a person with no symptoms, it would even still get their attention, but especially in a person who has lymphadenopathy and edema, which is seen in kidney involvement.
What would the biopsy tell you?
The biopsy shows you active lupus nephritis. So there are several different levels that I was quizzed on extensively in my fellowship, and it gives me PTSD to even think about. But the pathologists, there are 5 different types of lupus nephritis, and they basically tell you if it's active, chronic, how much is involved, and all of that is important when you're thinking about treatment. You would think about one type of lupus nephritis differently than you would think about another type of lupus nephritis. And it might, you know, who knows, maybe it won't show that there's any active lupus in her kidneys, which is great. That would mean that we can get her on maybe a less toxic medication before we get to that point. Because she's going to be looking at some medication toxicity probably with lupus in the kidneys. Okay, so this is another common consult, a 67-year-old woman with dry eyes, dry mouth, joint pain, and swelling in the parotid glands, which are right here over your cheek. And her PCP checked labs, and it's an ANA of 1 to 320 speckled with a positive SSA SSB. So if you'll remember, speckled is seen in lots of disease manifestations. 1 to 320 is not super high positive, but it's also not low positive. It's a solidly positive ANA. And then the SSA SSB antibodies are tightly associated with Sjogren's syndrome, also seen in lupus, but in this presentation with dry eyes, dry mouth, swollen parotids, this is probably Sjogren's syndrome. So Sjogren's is often education, reassurance, and consideration of Plaquenil. Sometimes we'll add more potent immune suppression, especially if they have involvement of their glands. But so this is what we'll be talking to this patient about probably. And then this is a common one too, a 46-year-old with fatigue. She has pain in both her muscles and joints, and she's gaining weight. So she went to her doctor who checked an ANA, which is appropriate. Fatigue is an appropriate reason to check an ANA. It is 1 to 80 speckled. And if I didn't include it, that means nothing else was positive, or at least nothing else was provided. So this is when I just need to know more. This pattern is common. This is a low positive ANA, and this is a presentation that is not normal. There's something going on with this patient, right? But it's not a specific presentation for lupus. So I'm going to want to see this patient. I need to ask a lot of questions. I need to take a look at her body. And if everything is reassuring and I don't see anything that's very specific for lupus, and we check the extractable nuclear antigens and they're negative, and her complement's normal, and her double-stranded DNA is undetectable, I might just provide reassurance and follow up annually or something of that nature. But this would not be like the first patient. This is one I'm not quite as concerned about. Okay, and that's just, and there's lots of, I see all forms and permutations of positive ANA and symptoms, and this is just kind of 3 scenarios I thought to try to put into context what we talked about.
Great. Any questions? Let's see, the window looks clear. I have a question. We, of course, recently had belimumab, Benlysta, approved for lupus nephritis, and we now have the first new drug since 2011, Lupkynis. What's the kind of the decision point between we're going to infuse you with Benlysta or we're going to give you a pill? Or has it been out long enough to even have that?
I have not used Benlysta yet for lupus nephritis. I was excited about it when Benlysta first came out. A lot of it depends on the clinical scenario in the patient. A lot of these are young women of childbearing age. So we're taking, you know, do they want to have children someday? We're taking that into consideration. We used to use Cytoxan all the time, and that can affect fertility. Oftentimes, if they have heavy proteinuria, which means protein in their urine, and they have a certain type of lupus nephritis called class 5, it's shown that we can use a pill for that one. Mycophenolate, actually, Judith, is the one we use for that. So I think it depends patient to patient. I can tell you that I personally have not figured out where Benlysta is going to fit in that. I'm anxious to find a patient that I can try it on. I need it to be someone that I'm confident it's going to, you know, this is important. I want the medicine to work. And so right. I haven't figured that out for myself. And anytime a new medicine comes out, you're kind of looking for that good patient that's going to be a good fit. And then after you use it a few times and you see the efficacy, then you kind of bring it into the fold a little bit more. So I'm not quite there yet. Maybe this new patient will be a good candidate for Benlysta or the other new medication. That particular stripe of medication that's related to tacrolimus and all that, I'm not as familiar with that either. Right. So I'm just looking for the right patient, I think. And hopefully don't get it, right? I don't want my patients to have lupus nephritis, but.
Let's see, when do you use Benlysta versus the Plaquenil routine for SLE?
I've been using I use Plaquenil a lot. All my patients with lupus or undifferentiated connective tissue disease, which I didn't really talk a lot about here. Undifferentiated connective tissue disease is where you have some features of lupus or you have inflammatory joint pain and a positive ANA, but you don't quite meet that criteria for lupus. All those patients get Plaquenil. Plaquenil is low risk, except if you get Plaquenil toxicity like Judith did. That's very rare. And it's really effective. So I always start with that. I am using Benlysta in my patients who have double-stranded DNA and have a lot of rashes and just joint pain that isn't fully treated by Plaquenil, especially in patients with a lot of arthritis and rashes is what I have. And that was the old indication before we got the lupus nephritis indication. So that, and that is the patient I've had success with.
What about for lupus?
I'm sorry, say that again.
What about for lupus?
The new medication?
The new one, yes.
I think that one is primarily used for lupus nephritis.
I think so.
Yeah, I don't think I would use that in a patient who just had, joint pain and skin rash. I would reserve that for a patient with organ involvement, specifically nephritis.
Okay.
Awesome. We're coming up on 7 o'clock. I don't want to keep you away from your family too long. I did want you to meet Pallavi Manuel, who is a postdoctoral research associate at Meharry, and she is has been part of our calls on Tuesday nights, and also is a member of our first class of Lupus Virtual Ambassadors. Pallavi, are you still on?
Yeah,
there
hi.
you are.
Hi.
Hi. I don't see you. I'm looking for you. Oh, there you are.
Yes, I'm here. Hi.
Hi.
Actually, your presentation is really very good, and I learned a lot from this presentation. And I am very much interested in the complement proteins. Like I'm studying the prevalence of anti-complement autoantibodies, anti-C1q and anti-C3b in African American and Caucasian lupus nephritis patients. And we have really observed a higher level of these autoantibodies in the African American lupus nephritis patients. And now we are trying to find out the mechanism by which these autoantibodies cause the tissue damage or the kidney damage in lupus nephritis. We think,
Do you think that'll be clinically relevant? Could you see us checking these antibodies in the future?
Yes, I think so. In long run, like because this is this is not a very big study. We have like almost like 100 patients, 50 patients of each racial category, but I think in the long run it can be used.
That's really exciting. We're always
along with the
anti-DNA
monitoring and the other stuff.
That would be great. We're always looking for, parameters for lupus monitoring. So
yeah, specifically for the lupus nephritis, I think this will be helpful.
Good. Well, thank you so much for your work in that field. That's
sure. Thank you.
Does anyone have any last minute questions? All right. Thank you so much. I knew you'd be wonderful, and I've been telling them that you'd be wonderful, and you just totally exceeded everybody's expectations. I had no idea what the 1 to 320 meant, and now I think we're all so much better educated now.
Well, good. Well, thank you so much for having me, and thank you for your interest.
Thank you. Well, will you come back?
Well, I can. I sure can.
All right. Awesome. I will get with you on that.
You guys tell me what you want to hear about.
Awesome.
All right.
We will figure that out.
All right. Well,
awesome.
Thank you guys so much.
Thank you so much. You are welcome to stay on the call. We're going to talk a little bit about the Food First program coming up. So you're welcome to stay with us, or you're welcome to.
I think I better get back to my family. I can smell dinner, but
oh.
But it's good to see everybody. Thank you so much for your interest.
Thank you so much.
Thank you.
All right.
Thank
Bye,
you very
everybody.
much.